As you guys have heard, as you know, is something that we deal with every winter, but it's especially important this year because of the development, the emergence of the novel H1N1 that we're now dealing with. The symptoms of influenza are certainly very well known to everybody and have already been reviewed. And the time frame of illness is something that we're also very familiar with. It's roughly a week to 2 weeks of being ill with about a week or so of really restricted activities, but that certainly varies from person to person. And ultimately, when we take a look at the pyramid that we've seen in a million different lectures, it's that 36,000 deaths per year, that's the mortality rate that we always talk about, but don't ever forget the tremendous economic cost to the system, the healthcare system as a whole. Anywhere up to $15 billion a year is spent on caring for patients with influenza, as well as for medications, as well as for vaccination and prophylaxis. So it's a tremendous impact on many different levels. And the impact on mortality very much mirrors in a lot of ways the incidence of pneumonia in the population during most flu seasons. So when we monitor several flu seasons, and this is 5 years from 2000 to 2004, we see that winter peak of influenza every year leading to mortality. And every few years there's what's called the excess mortality, that is the incidence of patients who die from influenza not specifically related to pneumonia. And that very much relates to the virulence of the organisms in any given year. And we'll talk about what makes up or what is required for a true pandemic to occur, but both the ability to be transmitted from person to person, as well as the virulence of each individual virus or viral type, are both important measures. And this excess mortality really is what relates to that virulence component in the pandemic equation. So when we take a look at the virus influenza, it's avian, it's wild birds, predominantly waterfowl like ducks and geese, that are the natural carrier of influenza. And there are in fact 16 hemagglutinin subtypes that have been identified in the bird population now, another 9 neuraminidase subtypes. And birds carry all of them, but not all of them are able to be transmitted to humans. So in order for there to be transmission, there has to be the ability of that hemagglutinin and neuraminidase to bind to respiratory mucosa, enter the respiratory cells, and then expand to release new viral particles. Humans have only been identified as being carrying H1, H2, H3, and now H5, which is the bird flu. Swine are carriers for H1 and H3, horses for H3 and H5. There's also flu that's identified in sea mammals, but we do not transmit or get those flus, at least to this stage. And what's important is to realize that avian does not spread directly to human the vast majority of time. They're the host for the virus, and they go through a secondary carrier, whether it's swine or whether it's domestic birds like chickens. And it's the back and forth mixing between these populations that lead to the variations that we see in any given year. And so as I said, H1, 2, and 3 infect only humans, or are able to infect humans, I should say, while H1 and 3 infect pigs, 3 and 7 are able to infect horses. And that just gives you an idea of the different types of influenza virus and their natural hosts and areas where they can be, or animal species that it can infect. Now the virus itself is a fairly simple virus. It's a myxovirus, RNA, with 8 specific proteins coded in the RNA core. The proteins are the hemagglutinin and the neuraminidase, which are the surface proteins which are responsible for binding and the ability of the virus to attack. The matrix protein maintain the shape and the structural integrity of the virus. And then there are another 5 internal core proteins, of which a number of them are required for polymerase, PA, PB1, and PB2. There are nuclear proteins, and then there are so-called structural proteins. And so these proteins are all part of that 8-protein structure of the virus itself. And this is just looking at it in a different way and how it envelops. And really, three-dimensionally, you can see very nicely how the virus is covered with the matrix covering the hemagglutinin and neuraminidase, and then your RNA in the inside with the various proteins that make up the core. These are your 8 proteins, and this is the hemagglutinin within the core, the neuraminidase within the core, M is for matrix, and the other proteins. So it gives you an idea of the structure, the shape of the virus that we're talking about. So it's a virus of the myxovirus group. It has relatively high infectivity, and the infectivity, as we've heard, begins actually before symptoms occur, generally 24 hours before symptoms occur, although in children you may see it even earlier than that. And it ends shortly after the period of fever, so 24 hours after fever. It's thought that you're not terribly infective, but that's not entirely true in all cases. The attack rate's fairly high. Anywhere from 5 to 20% of the population will be attacked by influenza in any given year, depending on the transmissibility of the given virus in that population. And subclinical infection is very common, and that's why the idea that, oh, we have 80,000 people 800,000 people who have had influenza. In fact, there probably were many more that had subclinical infection, never came to medical attention, never were sick enough even to be out, but are still have developed an immune response to it. And so that's why we see a variety of different numbers, and all these are extrapolated from other various studies, and whether they relate to the present H1N1 outbreak or not is certainly questionable. But it's important to realize many patients get the flu, and not everybody is severely sick from it. That being said, transmission we've already talked about, both from droplet particles as well as direct contact with contaminated material, and airborne spread from fine particles being a much less common medium of spread for the virus in our population. The key is that this is a cytopathic virus to the respiratory mucosa. Hence, our primary target is the respiratory tract, primary morbidity is in the respiratory tract, and it's a leading cause for mortality at the end of the day. And the characteristics we've already spoken about, and so with the 8 different RNA fragments. And it's really that hemagglutinin and neuraminidase that helps us to easily identify the subtypes. But just because there's a specific hemagglutinin and neuraminidase subtypes doesn't mean that every H1N1 is going to act the same, and that's what's confusing. Every year we're infected by an H1N1 type A influenza, not of this swine or novel subtype, to be politically correct, not of this specific subtype. So each H1N1 has different characteristics which lead to the degree of disease we see in the population and the severity of disease in that given population. Now, mutation of the virus is the confusing piece that some people have. And there are 2 different concepts about mutation. Antigenic shift, and we'll talk about this in a little more detail in a moment, but antigenic shift are much smaller point mutations which accumulate over time. It's a continuous change, as opposed to antigenic shift, which is a much more major change in the genome of the virus. And the importance is that you have far less immunoprotection when there's a full-blown shift in the viral subtype, as opposed if there's just a more subtle drift of the viral subtype. And we'll talk about that in more detail in a moment. But ultimately, when we talk about influenza A, we see epidemics pretty much every year. Some years are skipped, and occasionally there's been a 2-year skip, but for the most part, we see some degree of infection in the population, and whether it reaches the level of epidemic in a given year depends upon the transmissibility of the virus. But every 1 to 2 decades, we get a major pandemic, and pandemics have been traced back to this point to the 1890s, although it's not nearly as well studied as the 1918 Spanish flu, which is clearly the one that is our most well-studied flu, and set the stage for a lot of the science that have grown up from there,